giving them some, insurance doesn't have to cover sexual health things.
Right.
Insurance often has sexual health exclusion riders.
Yeah.
Right, so do not approve this for libido, it makes no sense.
Yeah. Wow,
Man.
that's.
That's
That's a lot
like
to
the
unpack.
biggest myth, but like that's.
Yeah, okay,
So
so
I
not,
cringe when people say it's only for libido.
so not only for libido, unpacking sort of the brain sex connection, which is so intuitive and common sense oriented. But where else do you find robust evidence for its impact and use?
So after.
Because this is where we start getting more controversy and people push it back.
Yeah.
And actually, let's just frame this because you and I talk about this and we live in this, we bathe in it. But I want to make sure everybody's on the same page around this. So we're talking about a couple of things here, right? The fact, and actually maybe we should go back a little bit and talk about what the FDA approval rescinding, because it was FDA approved at one time, was it not?
No, there was a patch in Europe that
Okay.
got removed from the market because it just didn't sell, and that was for surgical menopause. So I think people just didn't know about it, and that's a pretty small population.
Okay.
But in America, we've had two products go up for FDA
Yes.
approval. The Intrinsa patch has 4-year safety data at that time. Male testosterone had 6 months safety data and got approved. Viagra got 6 months safety data and got approved. Fezolinetin for hot flashes
Right.
got 1-year data
Yeah.
and got approved. So we have 4-year data on the testosterone patch. But wait, they went up to the FDA about 2 years after the Women's Health Initiative bomb dropped. And for anybody who doesn't know that, in 2002, the media went wild, misinterpreting data and saying hormones are basically dangerous. And so to go back to the question of what data do we have, we don't have research on hormones in the last 20 years
Because of that.
because of the WHO.
But we have we have data from
We have
decades
older data.
preceding. And I will say that I think there's a couple of reasons, in my opinion, I'd like to hear what yours is, that we are getting a lot of pushback, that we are getting this doubling down on the quote guidelines. And what the indicated uses for this would be. I think, and I'm gonna leave my opinion out of it actually for a moment. I'm gonna ask you
No.
exactly what you think. But, well, okay, we're not here for my opinion. I'm here to ask questions. But you know, I'll always get my
Yeah, yeah.
opinions anyway. I mean, I think it's complicated, but I think we're seeing this pushback in this area and this idea like that, again, like you said, testosterone is a hype, it's a fad. It's just another thing that people are trying to sell, and we're just like, how are we selling it? We can barely get it from patients. I'm not sure how that works, but whatever. Somehow we're selling ourselves on this. But there is data before we had this huge halt and no research money going to these things on testosterone receptors existing all over the body, right? So some of the things that I talk about with all of you, and you guys are probably more educated than average audience, you know, there's estrogen receptors everywhere, right? You guys know that. And testosterone, same thing, right?
Yeah.
So
It's only for libido. Why do you have testosterone receptors in your blood?
right, right. So tell us, what are the other areas of robust data on testosterone? Like, you know, obviously people come to us for energy, fatigue, mood, we really kind of discussed.
Yeah.
Strength, muscle mass.
Bone health.
Mhm.
Yeah. So I think the rub with the question is robust data
Yeah.
and what people agree is robust.
Yes.
Right. And in the landscape of there's currently no funding. We haven't had research in 20 years. If you want a randomized placebo-controlled trial to run for 20 years to prove you that this is good for your brain, you're never going to get it. So the question is, what do we do with the data that we have? Because you're going to hold your breath and pass out waiting for more data on this. We got some bone strength data. They did a randomized placebo-controlled trial, estrogen, placebo, estrogen plus testosterone. That arm had better bone strength and than estrogen alone. These are old studies. Nobody's looking at this right now. We've got the brand new JAMA study that came out as a negative study in 2025. This was hip fracture, older women, post-menopause, hip fracture, placebo plus rehab or testosterone plus rehab. They were not looking at libido. And at 6 months, the marker was, can you walk fast? Can you walk farther in a 6-minute walk test? The women on testosterone did not walk farther in 6 minutes. And that's a kind of a standardized rehab protocol, and they didn't pull that out of thin air. But testosterone, they're like, I love my testosterone because I'm faster on. Like, not something it's itself at. And what they did find is they buried this in the paper, so it's not in the abstract. Abstract reads like a negative study. In the paper, at 6 months, you had almost a 50% decreased chance of using a walker or a cane.
Wow, that's huge.
It is huge.
Yeah, wow.
Absolutely huge. And if I was a doctor and your mom had a hip fracture, and I'm like, I've got something cheap, safe, and she might be able to stay independent better at 6 months. No increased side effects compared to the placebo users. So I think that's the other part of the question is what robust data do we have? We don't have a lot, but I gotta tell you, we've got excellent safety data and it's cheap, right? And so it's like there's other things of like, this isn't something that is high risk. This is something that has 80 years of safety data. And another thing I said at the FDA was, what medication do we have where we've got a willing group of people wanting to take 10 times the dose, and we'll just see how they do, but we'll have them do it for like 50 years, right? Right? We have that with testosterone. They're called trans men.
Yeah.
We have a 30-year published study and a 50-year published study saying they're not doing any worse.
Well,
Right,
and let's talk about that, because not only are they not doing any worse, there are specific data on cancer risk, for instance.
Yeah.
Right?
But yeah, I mean, and now we're gonna start from the beginning.
I feel like we should, okay, we'll do the best we can. Okay,
Yeah.
we'll do what we can, but thank you, sorry for the interruption.
I mean, and I think we started out because we have to start out saying ovaries make this, it's very safe. Because the last thing I want is like, Kelly thinks everybody's gonna take this male hormone. It's like, you have to understand things enough to get to the level of thought leadership. But I'm like, let's talk about two things that scare the shit out of me. Breast cancer and dementia.
Yes.
We have data, and this is pellet data. We have pellet data showing a decreased incidence of breast cancer on women who are on testosterone.
And the pellet, I think most people who are on this probably know about pellets, but pellets tend to produce much higher levels than what we would in a standard practice. So these are people who are getting more than the average dose and decreased breast.
Decrease. So not only is it safe, this might be breast protected.
Yes.
Who's looking into that? Who's shouting
We know
that?
that from the trans.
Well, right. So when people say it's only for libido, I'm like, where's the Super Bowl ad for decreased breast cancer?
Yes, exactly.
Where's the National Cancer Institute studying this? Right? Like what makes a woman more feared than the risk of breast cancer? And we've got some testosterone data saying completely safe and likely decreased risk, especially in slightly higher doses, which is the pellet dose. Now let's talk about dementia. That's our second biggest fear, right? You think
It should be our first base.
Starting to
It is what it is.
but it's also safe for them.
Yeah.
So dementia. We have male data. That's the other run. We study blood pressure meds in men and we give them to women. We study statins.
And no one says anything
And
about
we
that.
give them to women. All this. We study sleep meds and then we give them to women. But we're like, not testosterone now. Like, but it's like in male data, men with low testosterone, where you give them their testosterone back, they have less depression and they have less dementia. Because this is a cognitive neurohormone that makes your brain work better. Alzheimer's influences or affects women way more than men. No cure, no good treatment. Why aren't we looking at everything we can to decrease our risk of our brain aging and causing these diseases? We have it in the male data. Why we aren't screening men for low testosterone at age 50, like many experts think we should, right? Because we don't know who has low testosterone in the male population. But to me, I'm like, we study everything else in men and apply it to women. We've got decreased dementia and depression risks with testosterone. And it's crickets. Right? Thank you. You should be, and I'm sorry, but anger drives energy. But I think the other, again, to answer the question again of like, what robust data do we have? we are ignoring the clinicians who day in and day out talk to women, dose testosterone, know that it's safe, and these women come back and they tell me how they're better. Not one woman comes back and says, it only helps my libido.
Yeah.
Because it's the brain.
Yeah.
And where I am now, and I'm actually talking to people to be like, how do I measure this? Is it's a motivation form.
Yeah.
What's libido? It's a drive towards, it's a pursuit of, it's a getting something done, right? And I just did a follow-up with a woman, surgical menopause, untreated, no hormones for 3 years. She had to quit her excellent job because of found estrogen, brain started to come back. She came to me. She's like, I think testosterone might be the missing piece. Let's try it. Just did the follow-up last week. And she said, I want to show you. So there's a telemed. She's like, I want to show you something. She takes me out. She shows me this new deck that's being built. She's like, that's my testosterone deck. She's like,
Yeah.
it's motivation.
Yeah.
I just want to do. And from my personal practice, I have 2 women who started businesses since starting out testosterone, but just in talking to people, I have about 8. But I can't go around on social media saying testosterone, it should be approved for starting businesses.
Right.
But that's what we see. And I think the expertise of the clinician is grossly and unfairly downplayed in this world where we're like, we need the science, we need the guidelines, we need the blah blah. It's like we'll never get an FDA approved indication for motivation. It's the brain.
Well,
Right.
we use medications that are FDA approved off label all the time.
All
That
the
is the
time.
practice of medicine. That's the art of medicine. You understand what I'm saying? So the FDA will approve this particular product for a particular reason, but in clinical practice, we know if we've got safety data, we've got efficacy data, that we will use it for a different reason because we know that it's safe and effective. And in clinical practice, you don't always wait for like science, as if science is a monolith or a religion, or it's fixed. Now we know this fact. This fact is a fixed. That's not how it works. That's not how the world works. The other thing that you and I talk about is guidelines. So this is my new thing. Guidelines are not the law. Really, guidelines are really important. They're guide rails. They give people basic information. But give us a quote.
Yeah.
Dr.
So there's a urologist who, his name's Dr. Abraham Morgenthau. He's got an amazing new podcast. Check it out. I'll plug it. And he's basically the urologist who said testosterone doesn't cause prostate cancer. And furthermore, we can safely give testosterone to men who've been treated for prostate cancer. Amazing guy, with an amazing body of work, and basically changed. There's a Nobel Prize for a urologist, so associating testosterone with prostate cancer. So there was a massive dogma that had to be overcome to change that. And
It's similar to breast cancer.
it's so similar to breast cancer. And I see that because I'm a urologist, right? But so he's the guy who's basically changed dogma. And on his podcast just a couple of weeks ago, he said guidelines are not for experts. Guidelines are for people who need a baseline understanding of things, but experts can't work to guidelines. Experts are up here, right? And that's what he didn't follow any guidelines to change medicine the way to help thousands of men the way he's helped them. And like I was telling you this, like I remember
This is gonna piss people off. I mean, it's fine. I'm happy to have the conversation. I think it's important.
Yeah.
But I think you all deserve to hear this. Like, this is kind of like the sausage factory conversation to some extent. So, but that's important because I think people are using this as a blunt tool against you and against us. Like the guidelines say, and I'm not against the guidelines, but the guidelines are not everything. And it takes like 17 years of data on our data. The data people love doing data. 17 years to get from solid, well executed evidence research to clinical practice. 17 years, that's a couple generations. And I think at this point we're unwilling to wait. We are experts enough to do this.
yeah, I mean, I've been taking care of women and people who want testosterone now for years and years and years and years and years. And for me to be like, well, I'm gonna wait, it's like, hold your breath. I've got 80 million women over the age of 40 who are headed towards breast cancer, dementia, heart disease, osteoporosis, hip fractures, and walking with a cane 6 months after their hip fracture.
Right.
Right.
If they're walking.
If they're walking right. And so to me, I'm like, besides your sex lives matter, and
Yes.
Viagra is one of the best known drugs in the planet. Who's taking care of the women who are supposed to be sleeping with the people that Josh is gonna know?
No, we love you.
So yeah, I mean, to me, I'm like, the sexual revolution started when Viagra came out. That was 1998. The sexual revolution will finish when we're taking care of the other 50%.
Yes, yeah. I had a random thought, because I started to think about this, which is, when we talk about optimizing hormone use, when we're talking about testosterone today, do you think that there's a role for starting to really understand what the optimal level for us in our younger years are, so that we can start to build on that? I mean, that doesn't maybe do anything for me or for someone in this room, but I have a lot of questions about that myself, because we don't have really good, and the reference ranges from labs are population based, and you can even look, this is in the weeds a little bit, not really. I had a conversation with someone recently who's a nutritional expert, and they were pointing out that things like ferritin, which is an iron storage product, that reference range has gone down, not because it is normal at 15, but because when it was 50, we've had a loss of nutritional value probably, and probably gut health, I don't know. So just so you guys know, when you get your labs and you look at those reference ranges, is that normal? Like, it's the norm, but is that what's healthy?
My new favorite quote is "Normal's the setting on the washing machine."
Yeah.
So the question is optimal, right? Which I kind of even cringe at the word optimal, because it gets kind of buzzy and
It does. It sounds a little longevity.
It sounds a little
Aging.
outside of
Yeah.
where I like to stay in medicine. But I think a good example of it is testosterone. So testosterone for male ranges 300 to 900 about. That 300 is the lowest 2% of men. 2 standard deviations, right? So, but what happens when a man goes to a doctor and he's got a testosterone at 304, the lowest 2% of men, he gets told your testosterone's normal and you don't get treatment.
Right.
And so I bring the male story into it to be like, this is not just a women's problem, like it's a problem with testosterone in general. And then, but women get that all the time. Your testosterone's normal, so you can't get treatment or whatever it might be. Interestingly, a lot of the baselines in Australia, and they had so much trouble finding women in their 20s who weren't on oral birth control.
Oh, no, right.
And what does oral birth control do to your testosterone?
Nice.
Tanks.
Right.
So they couldn't even get a baseline because so many people are on oral birth control, which messes with your testosterone. So that's very interesting. But I mean, in an ideal world, I'd be like, hey, remember when you were feeling awesome and you were 28, you had great sex and like great muscles, and like, did you happen to check your labs back then?
Right.
That'd be great.
I mean, I feel like honestly, just like I feel like I'm making this up, obviously, but I feel like I want to start doing that for my patients.
Yeah.
Yeah. Because we don't know.
I know.
We don't know.
Well, it leads to the next question of like, isn't it just natural for hormones to decline, and why are we replacing that?
Thank you for bringing that up and addressing that. I mean, because we get that a lot, like, and here's the thing, I live in a really interesting world where I actually, I mean, you know this, many of you who know me know that I am a great believer in progress in science, and also in traditional indigenous medicine, holistic medicine, and also in sort of being who we are authentically. And so I actually think that the menopausal transition is important spiritually, psychologically, and otherwise. That doesn't mean that I think that we should be denying ourselves opportunities to live our most authentic lives. For me, I take hormones. I support my patients who take hormones, who want to. I educate them because they are grown women who are sentient, who are really smart. They got this far in life. They're doing great. They get to make a decision. But if they do not have the education and the support and the resources, they're denying something they don't even know about. And I think there is kind of this like weird, it's natural, and so you have to do it a certain way. It reminds me as an OBGYN of the conversations around birth and physiologic birth, and that like if you didn't do it a certain way, and then it was wrong and you were wrong. And and it created this like either or rift that I think was completely false. And I see it happening again in menopause. Like if we educate you about what hormone replacement therapy, testosterone replacement therapy might do for you, we are medicalizing a natural process and denying you your experience. I mean, that is the messaging that I see, and I disagree with it. Too, but
Well, take off your glasses because they're not natural. Give me back the teeth.
Right.
that you've had worked on today. Take off your shoes because those aren't natural. If you've got here in a car, that's not natural. Like,
Yeah.
and I write about this in this book of the naturalistic fallacy. And it's the belief that because something came from nature, it is therefore superior or elevated. And it's such a good way to control somebody, to keep somebody quiet, to put somebody in their place. And it falls apart so freaking fast. In childbirth, 1 in 8 women or like babies died in natural childbirth, right?
Yeah.
And we cannot stand for that. And so it's this naturalistic fallacy of like, I'm going to put you in your place by telling you how you should do it. And I think it's also this like, it's kind of like halfway purity culture, right? Like you're doing something artificial, so you're not like the purist, and it's also this like perfectionism culture.
Yeah.
And it's like all of these things that come together, but when I call that out and you can actually see that for what it is, it makes you all the more solid in like, I'm choosing to do this for my health. You're not going to tell me not to replace my heart valve when I outlive it.
Right.
But that's not natural. But you would never tell me to not replace my heart valve.
Right.
That's like insane. But you feel like you can tell me what I should do with hormones? Like it doesn't make any sense to me. It doesn't hold up. I think the other interesting thing is the not feeling like myself, which is now being researched. And because of hormone changes in midlife, it's like 40 to 60% of women will say, I don't feel like myself. And to me, I mean, I gave up surgery to give women hormones because it's very nice when I can make people pee or not pee again and put their vagina back inside and all the wonderful urology things I did. But when a woman comes back and she says, I feel like myself.
Yeah.
Like that, I get women off of couches. I get them to start businesses and then they go and they make the world a better place. I'm like, it's the not feeling like myself is so incredibly important. But if you sit around waiting for the FDA to approve something for you to feel like yourself, it ain't ever gonna happen. And so it's really this like medical world where it's like, if I can't x-ray it and I can't lab test it and I can't objectively measure it, it doesn't exist. And I'm like, motivation, feeling like yourself, you're never gonna be able to objectively measure that. And that I think that's why there's this such a clash in medicine with hormones. Is like it's kind of an intangible thing.
Yeah. Yeah, exactly. How do you approve restoration of sense of self? I mean, like that's kind of it's so obvious when you see it and we know it, we feel it when we feel it, but how do you measure it?
Yeah.
And how, yeah. Talk a little bit about the FDA and your experience in July at the FDA.
It was awesome. Anybody watch it? Anybody? Yeah. For anybody who's online, the full 2 hours is on the FDA YouTube. My 5 minutes is on my YouTube. There's little videos you can go watch. So the FDA did a cool thing this year. The FDA said, we don't know everything about everything. So let's bring in some experts to tell us because we don't know. So to me, I'm like, that's a very like an expert knows they don't know everything. An amateur thinks they know everything, right? So to me, it was very elevated, I thought, for them to be like, we don't know everything, please come in. And so everybody who was there was at the top of their game as far as hormones go. And if anybody complained about that, because again, there's people who complain about it. One complaint is you guys agreed on too many things.
Yeah.
It's all suspicious. Right?
Yeah.
Like
It was
that was the complaint of like, like they picked you to all like say the same thing. And we're like,
well, maybe it's because it's true.
yeah, by large, just because the FDA is not at the forefront and they're behind, and like so many people agree on, right? And so it was awesome. And really the lowest hanging fruit is getting the box off of vaginal estrogen. It's completely incorrect at this point. It doesn't cause cancer. It doesn't cause blood clots. It doesn't cause liver failure. It doesn't cause probable dementia, which is all on the label. And 30% of women, if they are lucky enough to get a vaginal estrogen prescription from a clinician, 30% of them will not use the product because they read the label and they believe the label to be true. So that's the lowest hanging fruit of the FDA. But the FDA said, bring heart, bring stories, bring science. But they didn't tell us just to talk about vaginal estrogen. They said anything that the FDA can do to help women, let us know. So I'm like, I should talk about, I mean, that's kind of why I was asked, was to talk about testosterone. And we met beforehand, so we had a very nice presentation and we all helped each other with like, what's your message? How are you going to tell it? What do you want the takeaway to be? And it was just this great group. And every meeting, somebody said, I don't think we should talk about testosterone. And I would get tachycardic on my Zoom screen. But I'm like,
Did people say why? Did they feel like it was gonna pull focus away, or what was the?
well, some of the experts aren't testosterone experts, right? So they just don't know. They didn't, what the hunger for the box warning to be removed is so strong right now that it's hard for some people to think that we should be asking for anything else until we get this removed. And to me, I'm like, we can ask for multiple things.
Yeah.
We are adults, we can handle multiple thoughts. And so I would speak up and I'd say, this is why I think we should talk about testosterone every time. And then every time somebody else in the Zoom would then speak up and agree with me. I would say, yes, I think we should also, thank you, Kelly Plum. But it's like every Zoom, I was like, oh, now I got to put this up here again. But I have to tell you, he didn't see testosterone coming. Right? Like that was not, he wasn't thinking we were going to talk about testosterone. And so that was very exciting to give him something new. And he had a DEA meeting right after the FDA meeting. And for people who don't know, testosterone is regulated like Tylenol with codeine and ketamine because of the Anti-Doping Act of 1991, because of the significant abuse of anabolic steroids in sport. Right? I cannot make you a gold medal pole jumper by giving you female dose testosterone. It requires a lot of hard work.
You're killing my dream.
I know, right? That's another myth of like, are you telling women that they can just get muscles on testosterone? Is like, no, you have to freaking eat. It requires all the other things. But so bringing forth to say, I don't want this FDA approved for libido. When it gets approved, I want it deregulated by the DEA, at least female doses. We can fight about male doses and what we think about that, but for female doses, it should not be DEA regulated. Women use more telehealth than men do, and the telehealth companies are doing what they can to provide care, but DEA requires a state DEA license. Multiple states don't want other states to have, this is like fentanyl dealing level stuff, right? And I understand that. But we need to make access easier for safe, effective medications. And we also need to take the DEA's time and attention away from testosterone.
Yeah.
We've got big issues that the DEAs deal with. Female dose testosterone is not one of them. So that was my ask to the FDA. Give us a product, do not approve it for low libido, and get it deregulated.
That's cute. Hearing account. I mean, I was on the plane taking off. And then I lost it, but I got so it was amazing. It was really amazing. And Dr. McCary was supposed to leave the meeting and did not leave the meeting after Dr. Bright's talk, and your thing was like mesmerized. So the thing is, I think that was a really important lesson for a lot of us too, which is that, you know, if you're invited to the table, in my opinion, obviously the opinion of people who went to the panel, you may not love the host or the other guests, but you're invited to the table. I don't know. I was taught to be polite and show up and I'm curious. So that was the way we felt about it, and not everybody felt that, but that is what it is. But I think that was a really powerful and unexpected statement and moment. And I think it will be seen, honestly, as a pivotal moment for those of us who are working in this space, who are working to provide more equitable care. Again, that is evidence-based. Yeah.
So, and to me, I'm like, I know because I'm in this conversation, we've got multiple companies going forward for a female dose testosterone. Oh, so if I get my way, and again, I don't run the FDA, but probably 3 years, right? And it's going to normalize this conversation. It's going to provide access. And so like, to me, I'm like, this is just the start of this conversation, but how it's growing is women telling other women how they feel on it.
Yeah.
And that it's safe and you didn't grow two heads and you didn't have to remortgage your home for it. And like all the good things of like, this is safe, this is effective. And it's not a miracle pill. It doesn't help everybody. But for some people, it gives them their life back. They feel like themselves again. Like it is profoundly, profoundly important. And to me, I'm like, if physicians helping women feel more like themselves and have the energy to do what they want with the rest of their life, if that's not one of the most important things that you can do as a clinician, I don't know what the hell we're doing.
Right, and it is one important tool that deserves to be in the toolkit, because I think you've said this, but I want to be careful that people don't pull things out of context. It is not, if you want to feel like yourself, you must take testosterone. That's not what anybody's saying, but testosterone needs to be an offering so that people have the opportunity to decide what they want to use. Because in the context of lifestyle management, of preventative, longevity-based care, of primary prevention, which women don't get enough of, and is not part of the scope of this conversation, testosterone, we agree, should be part of the toolkit and in the hands of a skilled clinician can really benefit, and is really, it is not dangerous in the way I think it has been sold to us in a sort of a scare tactic way. I want to get to people's questions, but I do want you to quickly, you sort of alluded to it. I'd love to hear what you think the 3 to 5 year wish list plan is going to be in this area. And then you could just give us some like advocacy tips so that, because not everybody like you and I is going to be educated or open to a conversation with our patients about this. So
Yeah, I think 3 to 5 years, we're gonna get a female dosed testosterone product. And ideally, it's not gonna be for hypoactive sexual desire dysfunction.
but if not, we'll use it off good.
Right, we'll still say it's very hard to measure motivation, but my God, it feels great when you have your motivation back, right? And then I'd love it to not be DEA restricted, because that's gonna open up telehealth. And women are busy, we are the caretakers, we utilize telehealth more. And the DEA is already, and they did this last year, to say they don't want regulated meds being on telehealth. So this isn't just the testosterone, this is, ADHD medications, et cetera, et cetera. And so deregulating it is going to open up access, I think, for not just the menopause places, but for all the telehealth. And I think we're going to start, there's this fake, because it has to do with a period, that you can only use it post-menopause. And testosterone starts to decline after our 20s. There's nothing magic about a last period. There's zero magic about a last period in testosterone. And so again, this kind of stereotype, but I think where I see in 3 to 5 years, and this is menopause care in general, is that perimenopause women are completely neglected. They have low hormones, they just bleed, and so they don't get any care because of their bleeding. I'm like, give you an IUD, get your hormones because you're not bleeding. Like, it's totally made up. So the perimenopause population, and then this massively pissed in a good way, neglected population is age greater than 10 years post-menopause.
Yeah.
And why are we not studying testosterone more in the frailty population?
Yeah.
The sarcopenia, the osteoporosis, like massively neglected because they're not loud. They're not on social media. They were taught not to advocate. And like my heart, about a third of my practice is women in their 70s. My heart goes out to them because they said I turned 50. I had hit menopause when the WHI dropped in 2002. So how to advocate. My top tip is call a receptionist when you're making an appointment and say, does Dr. Jones deal with women's testosterone and hormones? Don't pay for parking, take off work, pay your copay, get in the visit, and then realize it's a helmet. Right? Like learn ahead of time if you can.
That's a great tip.
Ideally, if you already have a relationship with a provider, that's the best because they're a little more open to you. Like, hey, I know, like, and trust her already, right? So a relationship is good. I know it's hard in the current landscape. Bring in, if you can, bring in the testosterone for low libido international guidelines. Rachel Rubin says it best. She's like, the international world doesn't agree on anything. We have international guidelines for testosterone for low libido. It's like print them out, they're free online, bring them in. Just to say, hey, this is not just you watching something on TikTok. Like, this is a legitimate guideline at this point in time. And then when you're talking with your doctor, say, I would like to try X. I will make a follow-up in 2 to 3 months and we will adjust as needed. Putty in a doctor's hand, they love follow-up and knowing how you do.
Yeah.
This is not something where like, see you in a year. right?
Right.
Like, say, I will follow up and we will adjust as needed. I remember.
That's awesome. That's amazing.
Yeah, but need to add.
I mean, there's always, I like that because it's not an overwhelming list and a
Yeah.
very, very clear. I think what you said, and I think creating a partnership, I think, you all know better, but don't come in combative, like, oh, I heard you all suck and don't have any training. I mean, that's really not conversation with anybody.
He's like, you're part of the patriarchy.
Yeah, like, that's not gonna get you what you want. You get more honey with flies with honey than vinegar. So even though you might be really frustrated and this is your 10th doctor, and it is fully legitimate for you to be frustrated, try to do a moment of Zen and assume this person is going to be your partner and actually present it. I like the way you said it, like, give them the plan. But make them feel like it's theirs. Like it really does work because they're overwhelmed often. Okay, we could go on and on about that. Those were really fantastic. Do we have some questions? Yes, me.
Start with in person. Start with in person.
Let's start with some questions here. I'm sure there are many questions. Yes, yes.
What, if any, pitfalls do you see with an FDA approval? Both in terms of like guidelines or method of delivery, will we get restricted into a gel instead of a cheap vial that guys get? Like, what do you foresee could go wrong in that process?
It could be, they could put it in a pink box and charge $500.
Yeah.
Yeah.
The NFT approval will come from a company who makes a product a certain way. Absolutely. So whether that's, and I don't know what's coming first, right? But it's going to normalize the conversation. It's going to give us some, erectile dysfunction was in men's heads until Viagra got invented. Then it became a pump blood flow problem. But until we had a solution for it, there wasn't any way to treat it. So you guys got therapy. Right. And so it's really, now we're like, oh my God, it's a blood flow problem, right? We're like, don't forget the therapy sometimes. It's good for them. But, and I say that just to say, having a product sometimes makes something real. Right. And here we are being like, you guys, this is very real. But until there's a product for it, it's kind of an upward walk. So to me, I'm like, worst case scenario is going to be $500 in a pink box. Insurance isn't going to cover it because it's for sexual dysfunction, and it'll still be DEA restricted. So like it'll be what happened in Europe, which is they had a product, but it was only for surgical menopause, and nobody used it. So the company said this isn't making us any money. And so at the end of the day, I think when people go back and they're like, guidelines follow, like, there's money involved and there's businesses involved and there's government involved. And it's like, this is a big, big, big issue, right? But at the end of the day, the clinicians are like, I see women, I help them with this. I know that it's safe, right? Like that's all still true, even though we live in this very, very complex world.
Speaking of tools in the toolbox, could you speak a little bit to like the order of pet therapy or menopause, which, I listen to your stuff a lot online, and I have a support community where women are at all different stages. Some of them are terrified to start the patch. Some of them are already doing the patch. Some of them are going the pellet route and they don't do the patch or progesterone. So because not everyone is like us and like devouring podcasts and information online and cutting edge, watching FDA YouTubes like me, I want to help support, because I'm a community advocate. I want to help support women, like where to start and like how, because the peri, as you said, the peri community is so underserved. We're gaslit all the time. If you still have a period, you can't get anything.
Come back when you're more sick.
Come back when, when you can't, come back when you can't even get out of bed to come back. So just like when, at what point do you think is good to start testosterone? And I know that's hard because it's immeasurable, like how you feel or you don't feel yourself, you have no motivation.
Yeah.
But at what point do you kind of recommend starting testosterone if you're not doing anything yet, or how long you've been on, the patch, bioidenticals, and then starting testosterone?
Yeah. Good question. So for people who are online, because I've got the mic, just can't hear that. The question is like, how do you start the conversation with people who maybe aren't as self-educated and self-advocacy and with estrogen, progesterone, testosterone, where does testosterone fit in that lineup? And kind of perimenopause, it's a moving target, right? Perimenopause is reverse puberty. I would say start with health literacy. How does your body work? What do ovaries do? Right? Why do you have a period? Right? Because the more you just understand what your body's doing, the more, because if right, I don't even know how my body works, but she wants me to go on this thing that the bodybuilders use and dose on, like it's nuts, right? And so it's like, what happens in midlife? Well, ovaries are a certain size and they make hormones, but they have follicles that make the hormones. And at some point they just run out of follicles because they're only this big, like elephant ovaries are bigger, right? Like it's a size problem combined with a longevity problem. Not that any of these are problems, but here we are. So antibiotics alone, and I talk about this in my book because I really want to dispel the natural. Antibiotics alone increase the average human life expectancy by 26 years. That's insane. And that just happened 100 years ago. So us living to 84 as a population, generations have never done this before. There's always the outliers, and that's kind of where they are like, my great grandma's like, yes, she drank whiskey. I know she lived a long time. But by and large, like the human population has not aged like this. And so it's really just educating people of like, we have clean water, we have a safe food supply. By and large, we've got excellent shelter. We're not freezing to death anymore, right? Like we're living past the size of this many hormone producing cells. It's not because the ovary is bad or the higher spirits chose that. Ovaries are the size they are because of the size of the mammal. Elephant ovaries are bigger, dog, chihuahua ovaries are smaller. Like it just understanding that, because that opens it up to being like, oh, well, we live long enough and we only get one set of adult teeth. So we replace them when we wear them out, right? And so I just think it goes down to like, we don't know how our bodies work. And if we don't know how our bodies work, we can't just throw solutions at people until we get them caught up. And to be like, what do hormones even do? Are they just there for us to get pregnant? No, they make our bones strong. The myelin sheaths around the nerves, so our nerves can transmit. That's estrogen, that's testosterone. Like, but Google says these are sex hormones. Right, that's the other like why we renamed pet therapy is because I'm like, I can't say sex on Instagram. That's a problem, right? And it also kind of demotes these hormones as to like that's extra. You don't really need sex, especially if you can't have kids. Right? It's like these aren't just sex hormones, but we called them sex hormones because we discovered them in rooster testicles and bull ovaries, right? So it's like, yeah, I just think it starts with education, and then because it's still, if you come in here like, well, testosterone first or estrogen first, it's like they still don't know that they're outliving the hormone producing organ and what those hormones are actually for. And once they get that, then you can be like, I think the low hanging fruit is vaginal estrogen. Is like, well, get a woman on vaginal estrogen and face estrogen, and then she's like, I see the light, give me all that.
Yeah, that's really true. And I will say this, what I'm finding is that the perimenopause conversation is really starting to bubble up. It's really powerful. I think there's generational differences. I'm seeing a lot of patients coming into my practice much younger saying, I want to invest in my future. I don't want to wait till it's a problem. So I think some of this is going to get corrected by the demand of the millennials, who are just a very different population. The other thing is that there are, I mean, I'll plug it because I'm involved with it, but Perry has a new training academy for clinicians, for CMA, for like educational credits to get trained. The conversation is happening. And the last thing I'll say, because I hear this all the time, and I really understand, but I think there's this desire, and I think this is why people talk about guidelines a lot, for like a solution. This is the order in which we do these things. And that is not how it works in this area, because it is a physiologic developmental issue. And I think the bigger issue is people not understanding that this is going to happen. It is natural. And here are a variety of ways you can approach it with a partnership, a true partnership, whether it's people who are coming into your community, talking, destigmatizing and resourcing, or finding expert physicians and nurse practitioners and PAs who are in this room to work with. It is not going to be, you do this, then you do this, and you do that, and that's, we're not all the same.
Mhm.
So that, I know that's painful, but it's just the truth.
Mhm.
So, yeah, yeah.
So a few people are asking about what the healthy range is for menopausal and postmenopausal women for testosterone in both
Yeah.
blood levels and also like prescription.
Okay, so
Different questions.
Yeah, so the question is, what are healthy normal ranges?
during treatment.
During treatment or before the-
Well, the two.
So
Yeah.
a lot of the data on testosterone has found benefit without crazy risk in the high physiologic area. Now, to me, that means high double digits. You have to get a testosterone, if you're gonna test your testosterone, get it with the mass spectrometry lab, where it'll say woman/child testosterone or testosterone, comma, MS for mass spectrometry. The reason is the male testosterone lab isn't good at ranges under 100. It's just not, it wasn't designed for that. So if you use it, it's just not accurate. So we don't use the testosterone lab to diagnose low desire. We don't use it to prove that you can try it or not. They do recommend checking a baseline just to know where you are. I always joke and I'm like, because we want to find the mythical unicorn of the woman in menopause with high testosterone. Like she exists, positive. One of my colleagues found an undiagnosed PCOS, polycystic ovarian syndrome, right? So it exists, but it's really to be like where you are you absorbing it properly when I give it to you? Because I tend to do transdermal solutions, and did I move the needle on that? But there isn't you need to be at 86, and 87 is dangerous, and 85 is too low. And I use just one digit to be like, it gets kind of silly, right? To be like, everybody's a Toyota and everybody needs this. Of like, are you getting side effects?
Right.
Are you noticing effect? Are you noticing improvement? And if you're not at 4 to 6 months, they say, let's stop. But I tell people, this is how I joke. I'm like, there are people who've been on testosterone for 2 weeks and they're like, my brain is back. I am myself again. The sex is great. I'm telling you, all my friends, how great testosterone is. And I'm like, and then everybody else hates those people. Because there's the light switch effect that some people get, but sometimes testosterone, especially when appropriately dosed, takes 4 to 6 months to kick in. I don't push that up high. Hair follicles hate drastic change. And a woman who has thinning hair midlife hates hair follicles getting pissed. Right. So that's always my don't go from sea level to Everest Space Camp. It feels shitty. Like, don't have a low testosterone and push it super high fast. Some people love it. Some people, it feels really, really bad.
Yeah.
So go slow, start low, give it some time. But there isn't, so I'd say high double digits. If it's low triple digits, but I don't have side effects. I like being here. I know I'm going to follow her. Right. But so there isn't like a absolute cutoff. Plus, this is the thing that's like social media, I think, perpetuates is like lab values are not written in stone. If I check my hormones, even though let's say we're postmenopause and you're on pharmaceutical grade, if I check your hormones, that lab's gonna wiggle during the day.
Yeah.
It just is. How much are you using it? All these different variables. And so to be like, and I see this a lot with the estrogen dominance. Is like, I'm estrogen dominant for the rest of my life until I die. It's like, no, on Tuesday in July, I had a high estrogen reading.
Yeah.
Right. So people will do that with testosterone is like, recheck the lab. Maybe it was a bad lab, so we use labs as tools with well-informed clinicians, but we don't use labs as gold.
Right, exactly.
Did you add anything to that?
No, I think it's kind of what we're talking about also, like how reference ranges, where they come from and what they do and don't mean. No, I think that's perfect. I mean, look, I had a patient who it turned out was using her forearm to rub her testosterone. And when I drew it, it was like really high. And I was like, what? And I found that out. So we had to redraw. I mean, there are like weird little things that people are doing,
If you check your lab 2 hours after you apply your testosterone, it's going to be higher than if it's an 8 hour or a day after.
Yeah.
Right? Are you checking a peak or are you checking a trough?
Right.
And so like it's a tool, but it's not godly.
Yeah, and over-reliance on labs. This is a reason why over-reliance on labs can be out of context, can be unhelpful. Yeah. Was there anything else that was kind of coming out, and we'll try to take another?
Someone said that you talked about compounded testosterone cream, but if someone's not sure or not comfortable with taking that, could they also take general Walgreens or stocked
There's
testosterone?
so maybe what they mean by general Walgreens stock is a prescription for a male product. Yeah, because there's no over the counter testosterone. So I can't just go to Walgreens and be like, give me some testosterone. That doesn't work. So transdermal is, it's two ways mostly in America right now, is you can take a male product and you can dose it 1/10 the dose. That's a female based prescription, or you can compound a product and basically make it a female dose, usually, again, roughly 1 milligram, 5 milligrams, roughly 1/10 of a male dose.
And this is a specialty pharmacy that they make their own.
Yeah. So there is no FDA approved female testosterone. I can't give you the female testosterone. I have to make it via compound, or I have to use a male dose. Also commonly we can inject it. There is now oral FDA approved male products that go through the lymphatic system. So oral testosterone will hurt your liver. That's why it's not recommended. And that's why I get really pulled with troches, because there's not a lot of data to say how those troches are oral, sublingual.
Yeah. It's like a
They're
little
quite
liquid.
common in
That
some
comes from
circles,
Yeah.
but I can't tell you that doesn't go through your liver. Yeah. I can't, and it tends to be really short acting, so they're getting peaks and troughs more than a transdermal product. So troches are common, they're poorly studied. I like literally had a compounding pharmacist, I'm like, give me all your troche testosterone female data, and she's like, so that for that reason, because I am at the end of the day, I'm science-based, like give me the papers to read. I need it to be safe, right? So I don't tend to troche things as far as testosterone goes.
Is there a best place in the body? People are asking for,
Yeah.
for,
People tend to say lateral thighs, there's less hair follicles lateral. If you do it more medial, you might expect more hair growth, right? That's fine. I always joke with the legs of like, if a woman's hairy, she either doesn't care or she shaves. Yeah. Either way, it's fine. Right. So lateral thigh tends to be, again, in some circles, and this is getting, I understand it's getting in the weeds for some people, but this might help. In some circles, systemic means full body. Local means like skincare or skincare, right? But in some circles, to deliver systemic testosterone, they will have women put it on their vulva. I don't recommend that with the male gel product. It's got alcohol in it and can stink. But the vulva, just like the scrotum, has a lot of testosterone receptors and will suck up a lot of it. You could watch out for higher levels if you do it that way. I don't think for a systemic product, you need to put it in your genitals. Just like we don't tell men to rub testosterone on their scrotum anymore. So it's not designed for that. It's not well studied. So I tend to be like lateral thigh for a skin absorption. That's been studied. And I can't pass it around because it's a DEA regulated medication. I can't have anybody taking it. So this is one of the companies that makes a male, this is testosterone gel, 1%, 15 milligrams testosterone. So a man would use one of these a day. They come in boxes of 30. And women will have to figure out how to dose. And women are smart. We do hard things. We can figure out how to make this last 10 days. Right. So it's really a pea-sized amount, kind of like a pinky finger. They'll either do, this will come with a screw tab, so you can put this back on and it's airtight so it doesn't like absorb, because it gel, right? It gets absorbed. Or women will squirt this into a 5 cc syringe, especially if it comes in a packet that they can put the thing back on, and then do a half a cc a day to make it last 10 days. But I told Suzanne, I'm bringing my testosterone show and tell
That's
them
really-
I can't pass it around because
I've started telling people to put it in the syringe because I found that everybody's pee was not the same size.
Yeah.
yeah, is it organic?
And people were like microdosing it and like nothing's happening.
It's lasting a month.
Yeah. I was like, no. So hopefully
So is there any studies on people with dementia that are then given testosterone that have helped them with that?
There's male data.
Right, of course. But nothing for.
No, but our brains are not that different. Again, we don't have any female data as a reason that it doesn't work or it's bad and like, we study most things on men. And then extrapolate it to it. And to me, I'm like, it's a great loss to be like, dementia? Are you kidding me? There's no cure, there's no great drug. Why are we not studying a brain neurohormone that is cheap? Why are we studying this more? I think the answer is money. It's a generic medication,
Right.
like there will be no Super Bowl ads for this.
Yeah.
Right, but because there's no money in it, that doesn't mean we shouldn't be curious about dementia prevention in a world of. You're gonna live from most things. You're looking at frailty and dementia as the thing we want, because we're so successful at everything else, right? It's like we have this data and then why aren't we more curious to apply it to it? What do we have to lose, really, is the question. Like, what do we have to lose at this?
So we're trying to connect the dots between community education, education with our doctors, doctor education, and that's all fabulous. And thank you so much for being here. I want to ask about the managed care aspect with regard to testosterone, because it's not FDA approved. A lot of times, if you have a doctor, you're lucky enough to have a doctor that gives you the prescription, it can be blocked or it can be delayed. And so can you speak to tips on how to advocate for ourselves at the pharmacy, or what our doctor should be asking the pharmacy so that we get it sooner and avoid those roadblocks?
Yeah, are you speaking like insurance coverage or the pharmacist being the
Both.
barrier? Okay.
Oh,
it's
I mean, I have a lot to say.
Yeah, do we have an hour? So estrogen is labeled as a carcinogen.
Right.
Right, like so now, people are getting big stickers on their vaginal estrogen that says carcinogen, like it's so inaccurate.
Right.
But if you give high dose estrogen to it's like the synthetics, like the whole thing is wrong, but they're like, oh, technically it can change cells, and I'm like, that's how estrogen works, it changes cells, like that. But that doesn't mean you need to put a big carcinogen label on it, right?
Exactly.
So there's a lot of issues with the pharmacy and what regulations and what they're allowed to do, and pharmacists are also. I hate to use the word behind, but it's like they're busy doing other things. They're not exactly like, hey, do you know that the WHI has been debunked? And by the way, the hormones we use now are not even what was in the WHI. Like all the it's all from the WHI,
Yeah.
which is high dose synthetic hormones, right? Like
Right.
which if we always joke, if we're on a deserted island and that's all we had, we'd still take it. It's not that unsafe, right? But that's where it's all coming from. I've personally, I started doing a lot more compounding with testosterone, and the reason is the pharmacist.
Yeah, you're not gonna get pushback.
Because a woman goes into the pharmacist with her testosterone prescription, and either I won't break a box, because it comes with DEA restrictions, right? So you can only give certain amount of months
Right.
for the male product, and if you dose it female, then it's more than. So we got a big problem there. And then just fine, just give me 1 tube a day, and my woman knows how to dose it, but now give me the box, and then the pharmacist says, oh, are you transitioning? Like very inappropriate questions in public places.
Yeah.
Which, by the way, insurance often will pay for,
Not FDA approved for transitioning, but insurance will pay
Yeah,
for it,
but not for menopausal.
but not for, so if you want to
I've
transition.
gotten that denial and I have kept it in writing.
Yeah,
Wow.
we have. And the reason is the trans community is loud, and the insurance companies have listened to them.
And they deserve to do.
And they deserve to
They-
take
they
the
say,
phone. But so to me, I'm like, hey, what can we do? I'm like, get freaking loud, because
Yeah.
insurance companies do listen to that.
Yeah.
So to answer your question, the pharmacists are a problem, the regulations are a problem. Yes, compounding has issues. I know my compounding facility, I know my women on testosterone have good results and it's safe.
Yeah.
All of these things, and I know like compounding pharmacies do hormones a lot. That's why we actually don't know how many women in this country are on testosterone.
Right.
Or hormones for that matter.
Right, because it's working out.
It's bizarre.
Yeah, and these are database analysis through pharmacy databases and prescriptions. So we don't account for that. I think that the issue becomes access. I feel like that's where you're going with this, and I want to acknowledge that as an enormous problem. So I think the expectation that a doctor in a managed care situation will have the time to know about this and have the time to counsel is not realistic, I'm sorry to say. So I think you have to, if you are in that situation, I think this is where you advocate, you say, hey, I found out that there is this XYZ, are you willing to work with me on that? Because trying to use your commercial insurance and bringing it to a commercial pharmacy it's not going to work. almost.
Well, it's not covered. You're gonna have to.
Well, it's not covered, and even if you get like a good RX or something,
Right, yeah.
often there'll be all these other barriers and gatekeeping.
Yeah.
There is one pharmacy that I think we both use, HRT Club. They do not take insurance, they do not process through insurance, you have to join, it's $99 a year. And they get a lot of generics, including Testim and Androgel, and a lot of other products, some of which are brand name. And they sell it at a much reduced cost. It's quite affordable for the year. For some people, it is still going to be out of reach to spend $300 in the year.
Sure.
And that is not fair. And I don't know what to say. We're trying to work on this in all levels, but I think those are the hacks that I would really say avoid going to CVS.
Right.
Because they're doing what they can in the way they're doing it. And they're not equipped to handle this.
And Walgreens.
Any of them, just, as long as these particular, that has been my professional experience, and I think that's actually probably gonna work the best, because compounding can be fantastic, also be quite expensive.
Yeah.
But there might be a way to work with your local compounding pharmacist and see, like, especially if you're a community organization, and say, hey, we have this many women, can we work out a deal?
Right.
You know,
That's
I
great.
feel like a lot of them, the compounding pharmacists are really interesting people. These are old timey pharmacists who like make their stuff and care about things.
Yeah.
They're really creative. They've educated me over the years in many ways. I'm lucky, we're here in LA, and I have a handful that I know personally and professionally for decades. But you're right, this is hard enough for a person who's highly resourced.
Right.
Yeah.
Thank you for asking that.
Yeah, it's a very, very good, and it's part of like my advocacy of like, I can't have this be for sex.
Right.
Insurance won't cover it.
Yeah.
Doctors aren't good at talking about sex.
Yeah.
I need this DEA restriction off because it's expensive for doctors to get a DEA in multiple states, right?
Yeah.
Like the telehealth companies are basically throwing money at this
Yeah.
problem. We can deregulate this problem. And the other thing is, the companies that go forth to get an FDA approved, God bless them, but they do need to make a profit. That's how the world works. But if it's $500, it's not, we're still gonna use the generic cheap stuff.
Exactly.
And then they won't make, right? And so it's like, it's so complex. Besides the fact that women don't know what their ovaries do, right? So it's like, it's multiple problems. And when I try to advocate on social media about the challenges at pharmacies, because I want women to be like, it's not just you, like women across the nation have this problem, right? And then I get all the like, not all pharmacists, you know, and I'm like, I know not all pharmacists. But it kind of gets like that. Like, I don't want to say a group of people is doing it, but I want to encourage people to be like, why are we doing things the way we're doing? And is it benefiting women?
Let's do, let's see what time it is. Let's do 2 more questions.
Okay, thank you so much for being here. It's such an honor. I have a question from the lens of like an OBGYN who was trained in during the WHI, and who actually does a lot of outreach and education for women who are, going through the transition. What would you say? Because I get the question a lot, like, should I be on testosterone? Should I be on testosterone? They want to know, should I be on testosterone? Again, all I have really are the guidelines.
Yeah.
That say that X. Just from what you shared today, it sounds like every woman, because it is a hormone, right, that our body produces. So what is your answer to that?
Yeah, it's a really good question. And I get the same question all the time. And I'll repeat it for the people who are on the internet. Is how do I know if testosterone's right for me? How do I know if I need testosterone? It's kind of like all of those questions, right? And so what I do, I joke, I work really hard to make my clinic really easy because I have like podcasts and books at this point. So like they usually come in and they're like, give me the things I don't need this, I don't need the backstory, right? But for the average person who needs the backstory, and when they ask those questions, I usually start by saying, all ovaries make testosterone. Testosterone naturally declines with age. There is no FDA approved indication for testosterone in women. So I always start by laying out the story, right? Of like, I can't tell you what it's for. There's no FDA approved indication for it. We have a lot of data in sexual health. It's a brain neural hormone. There is data, we didn't even talk about this. Louise Newsom has amazing data coming out of her clinic looking at mood energy, and being able to get off of your antidepressant. Which is a whole new, it's a whole another hour of like, why are 25% of American women on SSRIs?
Yes.
1 in 4, and cannot easily come off of these things.
Yeah.
And Louise Newsom looked at women who came into her clinic, started them on estrogen, how many were able to come off their SSRIs by starting on estrogen, and then added on testosterone. Much higher were able to come off of their SSRIs because hormones modulate dopamine and serotonin.
Yeah.
These are neurohormones, right? And they're able to then get off of these medications. So I can present awesome data like that. Like some women find that their mood's better. I do not have an FDA approved indication. And where I'm always very cautious to get in trouble, especially on social media with my clickbait, is like, all women should do this, some women should do that.
Right.
But, and so like, I'm always very cautious. Now, in the thought leadership world, we can be like, dude, don't you think everybody should be on testosterone? And I'm like, cheap, effective, improves quality of life, ovaries make it, right? And so to me, I'm like, I can build the case of yes, but I will never go out and say, I'm Dr. Casperson, all women should. Although we're being recorded, right?
Very good. I want to pull that clip.
And so, like, that's kind of what we're up against, is like, it's too clickbaity to be like, all women this, no women that, blah, blah, blah. But really, I educate, I build the case for, and here's the thing, it's cheap. You'll know if it benefits you or not. This is not a leg amputation, right? Like you just stop if it doesn't work, right? Like it's really kind of low hanging fruit. And what I'll tell women is I'll give them other women's experiences. I'll be like, this is what women tend to say. Like, I don't hit the wall at 3 p.m. I'm not slamming back coffee all afternoon. I just feel like getting stuff done more. Somebody said, you know, that part in the Wizard of Oz where it goes from black and white to technicolor, that's my brain on testosterone.
Yes.
So we didn't even talk about sleep.
Oh, yeah.
Sleep.
Okay, that's a whole other.
Right, so I share because I'm like, none of these are FDA approved indications, but it's a neural hormone. It tends to help the brain. This is what women's experiences are. I don't push people for it. I'm like, if you want to try it, it's absolutely reasonable to try. I always, because if you got bloated, when did you get it from, right? So I always stack hormones. So we start something,
Yeah.
you're happy,
Yes.
okay, what's next, right?
Yes.
So I always do that. But to me, I'm like, your body, your choice. My job's education. And you know, I've started saying this on social media more. Is like, I actually don't give a crap what you do.
Mhm.
Like, I don't care. I'm not living your body, right? It's my body, that's your body. I'm not living it. I don't care what you do, but I care greatly that you're educated about it and you can advocate for it. And that's why I show up, not because I tell women what to do. And that's what I say a lot in this book is like, I'm not here to tell you to be on hormones, but you're gonna have all the receipts. So when people say we do not have data, you can say, yes, we have enough data to write 300 pages.
Yeah.
Yes.
Wow. Wow. That, I feel like.
Yeah.
We'll do that another.
Testosterone can help.
All right, so we're gonna call it a day. That was amazing. That night. And everybody in here can have the book, but I want to encourage everybody to go tell their friends to get the book. I want all of you to get the book. I can't wait to dive in. And just thank you so much for gifting us with your knowledge, your energy, your expertise, your sense of humor. Yeah, your amazing brain and the book. And